we've started to recognize and understand it more. Major depressive disorder, by definition, in its classic form, there are probably about um, 16 million Americans today. Um, and it's not a silent disease. It's substantially underdiagnosed, and only 1/3 of those who've had major depression get the help they need. Um, some are unable, some are unwilling, and some of them um, typically are faced with other concerns. The access to care, the stigma. Um, one of the concerns also is, and when we talk about the 16.1 million, is that they use the word depression and depressed loosely. So, for example, doesn't everyone get depressed from time to time? And if so, what we need to distinguish is the normal depressed mood and the words depression and depressed, and it can be confusing. So you can say, I'm so depressed after, for example, a rough patch at work, or when a favorite sports team loses a game, or an argument with a friend. But what I was trying to, just like in major depression, what you have to consider, if it persists and the feelings of blue linger on, and you are more unmotivated, listless, or irritable, then what you have to consider that it's major depression. So the severity and the duration and the other signs and symptoms that accompany the illness are concerning. You can't say it's a sign of personal weakness. You can't just wish it away. You can't just will it away. This is not something that you can just do. It's not one's fault. You can't blame somebody. It's a defect in chemistry. There was a term that you saw, and that was persistent depressive disorder. So we have to distinguish that. Until 2013, persistent depressive disorder was known as dysthymia. So what is this? Dysthymia is a chronic low mood. So it doesn't meet the criteria of a severe depression. It's a chronic low mood where you experience, and it's at least 2 years in adults or 1 year in children and teenagers, and it's not as crippling as major depression. It's if you think of depression as the color black, persistent depressive disorder is more like a dim gray. And unlike major depression, in which there's relatively short episodes, here in the persistent depressive disorder, there are long stretches, and it can actually last for like on an average of 5 years. It's this low mood, and it's just a blah feeling. The other sort of mood disorder that you've heard about is bipolar disorder. Bipolar disorder, and this is a concern. There's at least 3.6 million Americans today. That's a disorder characterized by ups and downs, and it's mood instability, and they feel unusually active, energetic, and the other term is manic. These mood swings are the hallmark, and you may have heard of symptoms like folks who have grandiose ideas. They feel like they're on top of the world. They don't need to sleep. They still feel energetic after that. They have periods of goal-directed activities. They feel like they're on top of the world. They have, and all of us have spending sprees, but these are unusually abnormal. They spend money they don't have. I mean, far beyond what is normal. Bipolar disorder is really the opposite of depression. nearly 1 in 10 American adults ages 18 and older has a mood disorder. Nearly 1 in 10 American adults today ages 18 and older has a mood disorder. That's how prevalent it is. This is the concern we had. I just wanted to review the symptoms of depression, which we talked about, the physical and psychological symptoms. You probably heard of the DSM-5. This is sort of the guidelines we have, and they usually would like you to sort of, in the DSM-5, have at least 2 weeks, but don't get focused on 2 weeks. At least, you have 5 of the 9 symptoms here, but take note, the biggest concern are the symptoms of the loss of interest or pleasure, and do you have the depressed mood. These are the 2 biggest symptoms that we worry about. Of course, the concerns of safety as well that we always worry about. But to be concerned about the diagnosis of depression, this is what we are looking for. So when did you get help? That's a big question you're always asking. When is the time, that you want to get help? Let me give you a statistic. There was a survey, I want to quote to you, 2016, of more than 46,000 Americans found that while 8% of the participants screened positive for depression, so out of the 46,000, they found that while that about 8% of the participants screened positive for depression, fewer than a third had received any treatment. Fewer than a third. So how do you know when the problem has gotten intense enough that you should seek a professional? Well, if you're asking the question, it's probably time to seek help. Depression isn't a one-size-fits-all illness. The concern is that it's like heart disease, it's like cancer. Depression takes on many forms. You should talk to a family member. You should talk to a loved one. We always encourage that if you think you have any of those symptoms, seek help. Whatever type of depression you have, be it the dysthymia, the major depression, even the normal depression, you shouldn't struggle in silence. And the depression itself can be so paralyzing at times that you feel hopeless and you feel like you're the only one struggling alone, which should not be which should not be the case, and that you should not find it hard to seek help. A vast majority of people who receive proper treatment for depression, rebound in a relatively short period of time. So even if your symptoms are vague, that shouldn't stop you from seeking out help. So who should you seek for treatment? And there are different people you can seek out. And I can go over these and you ask me questions. The primary care physician that you have is that can be your first stop. A primary care physician is he can assess your symptoms. Primary care docs, family physicians, pediatricians, they've got a good eye to whether you have an underlying medical problem. They're very good folks. If they believe that depression is the main problem, they may or may not prescribe you an antidepressant. And sometimes the first initial the initial response is good, and you may not need to go further. primary care docs are doing more and more mental health treatment, so yours may be comfortable doing that. If your situation is more complex, they may then refer to you to a psychiatrist, psychologist, psychiatric mental health nurse practitioner, social worker, licensed professional counselor, peer specialist. And you can ask your primary care doc what is in your insurance company for referrals. Kathy is a wealth of knowledge. She can, I'm sure she gets calls all the time, right, Kathy?
I can send you to the right person who can answer that question.
Psychiatrists. These are MDs or DOs. These are folks who they've had training in medical school, and they've had additional training in residency training. Psychologists are PhDs or doctors in psychology. They have clinical, educational, or counseling and research psychology. Psychiatric or mental health nurse practitioners, they have a 4-year college degree in nursing plus a master's in science in nursing, or a doctor of nursing, and they're licensed in many states. They can prescribe under a psychiatrist nurse supervision. Social workers have a master's degree or a doctoral degree. A licensed professional counselor also has a master's or an MA or a master's in science, and they have typically 2 years of supervised postgraduate experience. A peer specialist has a personal experience with mental health issues. So there are a lot of folks you can seek for treatment. There's a lot. Medication therapy or both. Medication therapy or both. No single approach works for everyone. No single approach works for everyone, and it's always individual. And I have this, discussion with, patients. It's always risks versus benefits. The research has shown that both will enhance your recovery faster. Some folks do better with just therapy. Therapy has no side effects. No weight gain, no nausea, vomiting. Medications, some people prefer just medications. And that way they're happy and they do well. And they, after 3-6 months, when the medication has kicked in, they decide to go off it, and we discuss the risks versus benefits. 3 months later or 3 years later, a stressor comes in and they decide to go back on the medication. And one good barometer of knowing what medication is to start them on is the one they were previously on. If your depression is mild, then there's a greater chance that you will respond to therapy alone. And again, Kathy if she gets calls, therapists in your network, those folks that are available right away. I think you have an EAP, an Employment Assistance Program. They also help you with that. How do I cope when a loved one is depressed, suicidal, or manic? So this is very important. You try at best to offer emotional support in at best a non-judgmental way. It's a difficult scenario when you have that dual relationship with someone. You love the person and you're trying to be supportive, and you're trying to tell them what to do in a way where they're not getting offended. It's very hard. Encourage him or her to get treatment and stick with it. So once they're there, you gotta tell them, you gotta stick with it. Okay, now that you're there, what are the consequences? Because if they don't stick with it, they're going to relapse. They have to follow the protocol. And they'll say, oh, you know what? You can't tell me what to do. You won't be my friend anymore. I won't talk to you. Yeah, but then, I'm sort of responsible for you. That's very difficult. I'm put in a position. You called me, and then, this is where I am now. So what's the use of you getting the help if you're not going to stick with it? It's very difficult. So before you get in, you got to get that mindset. What am I getting myself into? And you need help for yourself too. This is being a caregiver is caregiver burnout has been a cause for depression itself. You well know that. Support groups are very important. Don't ignore comments about suicide. Right. That's also very difficult. They'll say that on the side, and what do you do with that? What do you do with those comments? That's a sign where they're probably, in a way, asking for help. And an adult should, at all times, take it seriously and talk to the person. And in a way, talk to the person in a judgmental way. And if you still feel a concern, there are crisis hotlines. If you still feel a concern, there are ways to navigate, taking them to help, to get help. If necessary, take them to the emergency department, call 911, or importantly, the suicide hotline. This is a concerning too. Try to prevent reckless acts during manic episodes. What does this mean? If you have to take away their credit cards, take away the credit cards. They may not appreciate it at that time, but if they know that you have their credit cards and their driver's license, at the state of mind that they are in, they don't appreciate the damage they can do to themselves. They may hate you for now, and they might be angry at you for now, but later on, when they've recompensated or they've been more stable, they'll realize later, thank you so much for saving my life. So at the state of mania, that's putting them at risk. Practical tips. Kathy knows this more than I do for this crew. All about the wellness. And these are things that help very well about wellness and trying to get help, and trying to do that best. Trying to, learning about the mood disorder and all these things. These are some of the resources, and we can do that. Any questions? Questions? Yes.
If depression is a chemical disorder, how does psychotherapy combat or fix that? Unless you're also taking medication.
So it's a multi-modality. Let me give an analogy. It's like diabetes. I might have an insulin problem. Now, the good thing with diabetes, I can come to you today, and my fingers stick. The last time I remembered, if it's below 126 or 130, I can say with certainty that it's below a certain level, and I can have this discussion with you, and you might say, it might be helpful if you started using insulin. So that's black and white. Or you might say, you can hold off on it, and if you start, Ben, my first name is Ben, if you started using some diet and exercise, and switching to a lot of fruits and vegetables. So in my mind, I told you I like the macaroni grill. I love pasta. That's not going to change. My mind has been wired. It's going to take a whole lifestyle. So you're going to refer me to a nutritionist, and it's going to be a lot of modification. So I'm just going to do the insulin, because I want a quickest way to do that. So I'm going to probably do what you're asking me to do 10 or 20% of the time, but I'm going to do the insulin. Other folks might say, you know what, I'm going to try this. I'm motivated to do this because I don't like pasta that much. I'm going to try that. So you bring up an excellent point about therapy. What is the purpose of therapy? There are different kinds of therapy. So one, for example, I'll give you an example, is cognitive therapy. I may have come late for an interview. So it's 9 o'clock. I actually came late today, but this is more important, and it is. But there's also an important for a job interview. So cognitive therapy is, without belaboring too much, cognitive therapy was designed for folks who had panic disorder. Panic disorder where it's so debilitating, the anxiety. It overtakes our lives. And the psychologist designed it so that we could control panic without medication. So it's not rocket science. So I'll give you a specific example how it really works. Your interview is at 9 o'clock, and you came and you practiced the day before. Let's say I'm interviewing for Gray and Son, and I practiced the parking lot. I'm supposed to make a right, but I missed it. But how could I not miss it? It was Sunday when I practiced. It so happened that Monday comes at the time of my interview. All the traffic, the perfect storm happens, even if I practiced. And my interview at 9 o'clock, I still come at 9:30. And everybody showed up at the parking lot. So the first thing that's happening to me is I'm late for the interview, and the first automatic thought is,
Where do I park?
where am I going to park? Next,
Well, I missed the interview.
I missed the interview. Next,
I'm not gonna get hired.
I'm not going to get hired. Classic panic attack. It's the end of the world. So that's a catastrophic feeling. We see that all the time. So I work in crisis work. I work in the ER. It's like a heart attack. I'm going to run to the ER, palpitations, diaphoresis, feelings of doom. It's the end of the world, doc. The guy's 28, healthy, no heart problems. But he's coming in there. What happened? I missed my interview at Gray and Son. Why? I couldn't find a parking. I'm going to die. So we're like, oh, okay. We did an EKG, everything's normal. So what do we do with cognitive behavioral therapy? They would say, what's the evidence? What's the evidence that you are, it doesn't work all the time, but what's the evidence that you are going to die? If you've ever talked to a panic disorder, is very common. Millions of Americans have it today. So what's the evidence you're going to die? If you talk to anybody with a panic disorder, what's the evidence you're going to die? There is none.
None.
what's the evidence that you didn't get the job?
You don't get hired.
You say, well, I couldn't get a parking space. I came late. Yeah, but what's the evidence you didn't get the job?
They may not even let you interview later on.
But you didn't go in yet. You could have gone in and, oh, the manager's also late because he couldn't buy a parking space. But we don't know that yet. But what happened is the automatic thoughts already took over and you reacted to them. That could be a family history. There's a legitimate reason for you, but you reacted to that. So the automatic thoughts. So in cognitive therapy, and it occurs over 6 to 12 sessions, it's designed to help you block the thoughts. Somehow repeated over and over and over conditioning. Conditioning over and over and over again. That conditioning helps. It doesn't work overnight. Therapy takes time. And you have to work with that. What is the evidence? And the guy said, I'm not going to die. But that's what happens in a panic attack. Your catastrophic thinking. So when you go there and you say, oh, okay, why am I sweating? Why am I thinking? But there's no evidence you're going to die. There's no evidence that when you go and so for folks who are afraid of heights, you're not going to fall. But what's the evidence you're going to fall? Now, people have legitimate fears of heights, but it takes a lot of conditioning. It takes a lot of work. It takes a lot of work. And there's the conditioning. Just like when you're running, you don't just run a marathon. It takes practice. So that's an excellent question. You're conditioning the receptors, the brain. So